Up next, Richard Conti is joined by Kathleen Biga, a registered nurse and CEO of Cardiovascular Management of Illinois, on data collection for beginners.
The first thing I want to ask you, Kathleen, is what do we mean by data collection for beginners?
Data collection for beginners is really defined as, in our medical world and in a physician practice, they are receiving data daily. And our intent and our goal is to try to coordinate all of the data that's being collected on physicians and organize it so that we can actually use it in our day-to-day practice.
Okay, for example, the only data collection that I know of for beginners would be collecting for core measures. Is that one of the things that you do?
It is. There's probably about 60 data sources out there that collect information on physicians. We like to narrow it down when we first start to several things. One would be core measures, and specifically in cardiology, we look at AMI and CHF core measures, although there are others. We also look at NCDR data registries, such as CathPCI, ACCEL, ICD, and work with the physicians on where to find that data and how to use that data. And then there's all the data on the private payer report cards, and soon all of the CMS data that will be gathered on physicians, and really start to isolate those data elements to make sure a couple of things. Number one, that they're accurate, and number two, that if they're not accurate, there's a process that we can go through to correct that data, because as we know, transparency is evolving, and our data is going to be available on the internet and for public consumer watch, and so we want to make sure that our physician data is accurate. So the data collection for beginners is how to start that process.
Well, it sounds like you have your work cut out for you. But I think that you hit a bell here when you said the word accuracy. And I think that's what we all need, is accurate data, so that we are not thought of as poor physicians or good physicians based on incomplete or inaccurate data. How do you do that? Let's just focus on core measures, for example, for heart failure and myocardial infarction.
And core measures is always a good place to start. And the first thing you have to do is make sure you've identified what patients will actually fall into those core measures, to make sure that the data that we're collecting on them is not only accurate but complete. And we'll just fast forward to one of the areas that probably impacts the physicians, specifically the cardiologists, the most on this, and that's MedRec, medication reconciliation, for that discharge instruction piece. One of those ones you probably see in daily practice, and you hate getting those phone calls from the case managers and such. So what we've done in our organizations as part of our integrated approach to core measures is we identify a physician champion. And once a month we change that physician champion because it can get a little tedious. And we have found that our core measure scores have dramatically improved by just having that ownership of the data.
Is that a volunteer physician that does that?
It actually is, but what we've done is we've embedded it in our service line. By reaching our core measure goal, there's actually a compensation that's tied in the physician. This kind of starts to evolve us away from a fee-for-service into a pay-for-performance and actually pay-for-quality. So that's how we've done it.
Sounds like he or she ought to get some RVUs for doing this.
Funny you should mention that. We do give them RVU-like credit. So there's so many activities, as you know, for a physician that is not RVU defined by CMS. We call them non-RVU producing activities, and this is one of the ones, and they do get paid for it.
Let's focus down on the actual doing of this. Let's say somebody comes into the emergency department and they get a troponin that's 0.1, which is probably abnormal. What's the actual mechanism? What do you do with that information? How do you ensure that somebody's doing the right thing?
So when you're doing your data collection and starting that whole process, you pick a very good example. What we did for AMI is we run a report every single day on troponin levels. Those troponin levels then go to a nurse who visits those patients, and we tag them, for lack of a better word, as being a potential AMI core measure participant. And therefore, you can start going through your measures, your Aspen on arrival, and the different components in AMI core measure. So it's a very solid way of ensuring that we don't miss any patients that fall into the AMI core measure.
Okay, that sounds reasonable, but who are these patients that go through and look at these troponins and see what's going on?
Every hospital does it different. We actually have a core measure champion who's a nurse. And of course, they can't work 24/7, so you do need to make sure you have a process in place, but they are a nurse, and they happen to be housed in our cardiodiagnostic department, the ones that do our echoes and our treadmills and our stress tests. They're responsible for that process. But Maybe we could look at another way, too, which would be some of our NCDR registry data. That's another one that physicians need to understand how to start to collect that data and use it as a roadmap for their patients. That's something that we have found we don't have enough physician champions for, looking at our Cath PCI or ICD data. And it's not that the information isn't there, it's that we aren't perhaps documenting it well, or perhaps we're not abstracting it. So just another way of making sure is you've got this myriad of data points and data elements out there that we can corral it for the physician who's very busy and target what we need his or her input on.
Let me give you another example of what I see a fair amount. I told you before we sat down here that I meet with our nursing staff in what's called multidisciplinary rounds. And we talk about core measures. And I don't always know the patient, and the nursing staff doesn't always know the patient either. But the resident staff should know the patient, and they should be probably involved in this kind of a meeting that takes 15, 20 minutes every day. Mm-hmm. Let's use another example of heart failure. I don't know how many times I've asked the question, why did this patient not get an ACE inhibitor or an ARB? And the response is, well, the patient's creatinine was a little elevated. To me, that's an indication for giving it, but it's hard to get that across to everybody. How does this person who reviews this chart look at those kind of things, and how do they check it out?
Well, and I think we have to be careful here that we have the physicians driving the care of the patient. We have somebody that needs to team with that physician to focus him on what might be needed. And I think that's the area that you're highlighting specifically. For instance, in that particular case, the patient doesn't have to be on an ACE or an ARB, but it has to be documented as to why they are or are not. So we'll leave it to the physicians for the clinical judgment, but I think you're absolutely right. You want to raise that question. Now, the best thing to do would be to get our electronic health records working so a flag would come up or an alert would come up. Then we could eliminate this human nature where it just doesn't happen. If we could get our systems and our vendors working with us to embed these core measures or the core pieces that we need for our registry data, then we really have meaningful use of our electronic health records.
Our medical staff is actually working on that aspect. We use Epic, which is not the easiest system to use. I agree with you. It should be embedded. It should be automatic. You shouldn't have to think about it. Just do it.
Right.
We're getting there, but we're not there yet.
In the practice setting, many of our physicians that are doing PQRS or meaningful use have got it embedded in our records. The issue, of course, is the hospital records, Epic, Cerner's, Meditech's, much more complicated.
Yeah. Okay, let me ask you about medicine reconciliation. You know, one of the problems that we have is that when patients come into the hospital, they have a long list of medications, and what needs to be made sure is that these same medications are given to the patient when they discharge. How do we deal with that?
Boy, I wish I had a magic bullet and the right answer for you and our audience. It is the most difficult thing. We've tried everything. We've tried refer to dictation. We've tried checklists. The bottom line is MedRec, medication reconciliation, is so specific you can't even add a vitamin that doesn't reconcile back to the record. My best advice to the physicians, if you can say refer to dictated records so there's no variance between your medication reconciliation and your discharge summary. If there's only one place that you put your data, then you'll be successful. We recommend that it's in your discharge summary and you simply refer back to the medication list.
And the beat goes on, so they say, but there's still more to learn about all of this, and I'm sure there'll be a lot to be talking about in the future. But for the moment, I think we've covered what I'd like to cover, and I thank you very much for coming to ACCEL and sharing this with us.
And I appreciate the opportunity. Thank you.